Good afternoon, everyone, and welcome to today's webinar. Today's webinar is themed Structural Barriers in Mental Health Care Among Latinx Populations, Means Strategies, and Resources to Improve Access and Services. With us today is Dr. Hector Colon Rivera, who will be today's presenter. I would like to acknowledge, firstly, that this presentation was prepared by the National Hispanic and Latino Mental Health Technology and Transfer Center under a cooperative agreement with Substance Abuse and Mental Health Service Administration, SAMHSA. The MHTTC network uses affirming, respectful, and recovery-oriented language in all its activities. This language, as you can see, is strength-based and hopeful, inclusive and accepting of diverse cultures, genders, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and is consistent with our actions, policies, and products, such as this webinar. A bit about today's presenter. Dr. Colon Rivera is a distinguished quadruple board-certified adult addiction psychiatrist of the Pennsylvania medical community. He's currently a faculty member at the University of Pittsburgh Medical and the Einstein Medical Center. He has broad experience in community-based programs, emphasizing those that help increase access to severe mental illness and substance use disorders treatments in minorities. He's the medical director of the Asociación Puertorriqueños en Marcha, Inc. Behavioral Health Program, APM, a nonprofit organization dedicated to improving Hispanic communities' quality of life through direct behavior and substance use disorder services in the Philadelphia region. He's also the co-founder of Crear con Salud, a nonprofit with the goals of supporting conducting educational research and advocacy activities to increase public awareness and action regarding mental health in Puerto Rico and Latinx communities in the United States. Dr. Colon Rivera has served as a clinical advisor for the Advisory of Alcohol and Other Drugs Committees for Pennsylvania and the Opioid States Targeted Response Technical Assistant Senior Advisor to Puerto Rico. He's the president of the Hispanic Caucus and a member of the Assembly and the Council of Communication at the American Psychiatric Association. So we will now go on to our pre-questions.
Thank you, Eric. Participants will be seeing the questions on their screen. I will help them through them. First question says, blank, a way for healthcare professionals to expand talent by pairing less experienced workers with those that have more experience. It's a multiple choice question. You can choose whatever you feel is the most accurate. Once again, blank is a way for healthcare professionals to expand talent by pairing less experienced workers with those that have more experience. One more time, the first question is blank is a way for healthcare professionals to expand talent by pairing less experienced workers with those that have more experience. You can vote selecting in your screen. Going into our next question. Cultural involves a particular set of beliefs, norms, and values that influence ideas about relationships and how people live. This is a true or false question. Cultural involves a particular set of beliefs, norms, and values that influence ideas about relationships and how people live. This is question number 2. Participants can answer selecting directly on the screen. One last time, cultural involves a particular set of beliefs, norms, and values that influences ideas about relationships and how people live. True or false? And our last question before we move on with Dr. Colon's presentation, the particular type of health differences closely linked with social, economic, and/or environmental disadvantage is defined as, once again, multiple choice question. The particular type of health differences closely linked with social, economic, and/or environmental disadvantages is defined as the particular type of health differences closely linked with social, economic, and environmental disadvantages is defined as, once again, true or false. Sorry, multiple choice question. Alrighty, we have almost all participants answering. We'll give them just one more second. Thank you everybody for participating in this questions. Dr. Colon, all yours.
Thank you for the presentation and thank you for the invitation. I have no disclosures. I have no conflict of interest. And again, I'm Dr. Colon Rivera, Dr. Hector. That's how people, call me in the clinics because they always mix up my last names, and that's something that, is cultural. When we talk about cultural competencies, that's something that we need to teach and our staff, right? Recognizing that something we use two last names. So we will talk a little bit more about that. But in terms of where do I work? So I'm an employee for University of Pittsburgh, and I work for APM. At APM, I'm the medical director. As Mr. Senior mentioned, I'm the medical director, and we are a nonprofit. We have different departments, including education. We have foster homes. We have housing departments, and one of the questions, right, you talk about social determinants of health. So we try to touch all the social determinants of health because that's how we see the community, how we see the society, and how we see the best treatment for our patients. And we will talk a little bit more about that and how we can increase access. And that is cultural competence to our patients. We use cultural competence as that wording. Some people call it cultural humble, cultural adherence, but cultural competence just because most of the research out there use that kind of words or terminology. I work for University of Pittsburgh. I do mostly telemedicine with them. I run an inpatient unit. And what I do for them mostly is access to rural areas in Pennsylvania. If you're familiar with Pennsylvania, it's a huge state with nothing in between Philadelphia and Pittsburgh in terms of treatment. So what we do is increasing access on those areas in between Philadelphia and Pittsburgh. I've been doing that for almost like about five years now. So even before the COVID, we were really into telemedicine. So if you have any questions about how telemedicine works and how can we improve access to treatment for Hispanic Latinx communities, please use the chat or we can talk about it after the presentation. In terms of nonprofits, I also I'm the founder, co-founder, right, and member of the board for Crear con Salud, which is a nonprofit in Puerto Rico. So we travel to Puerto Rico pretty often. We also do webinars every 2 weeks in Facebook and YouTube in different topics about mental health and health in general. So look at us and Facebook, like us, and share our posts. And of course, we always take donations. So today we will talk about really interesting topic that we can talk for weeks, and we only have one hour to talk about it. But it's about the structural levels and barriers that impact mental health and health in general. I mean, access to health for Hispanic and Latinx communities. I'm going to talk about 3 models in particular that I use with my staff, use in the nonprofits that I oversee, and there are models that help to improve the access in a cultural way and grounded and responsive, to respond better to the mental health care needs of our population. Also, we're going to discuss means, some strategies and recommendations to develop a better, community-based support, which improve, of course, mental health in our clients and our population. A little bit of history. We only been talking about culture and health together, right? Those two terminologies for about maybe 30 years. It was not until the 90s, late 90s, that the Surgeon General released a mental health report, and then that was attached to a different bill, and it was not until 2001 that we start talking about culture in health. And I like elephants and talk about. I mean, I'm addiction psychiatry, I'm a licensed psychiatrist, so I try to deal with the elephant in the room and with all my patients, and there is a lot of, when we talk about Hispanic X or any type of cultural um, or diversity, right? There's always this elephant about the denial, right? The avoidance, the guardedness, the diversion, about talking about this topic. And we see it in Twitter, we see it in social media, we see it in the news. Every time we turn on the TV, we see something related to diversity. I mean, we saw it in what happened with stigma, violence, and mental health, and every topic we touch. We saw it during COVID-19. We see it on the war with Ukraine, Russia, with Will Smith a few weeks ago. I mean, that topic keeps coming and coming, and we're always talking about cultural health and mental health. So there's always the big elephant in the room. And I hope after this presentation, you feel more able to touch this topic with your staff and your patients to improve the care of our patients. And we know, I mean, Hispanics and Latinx communities are here to stay. I mean, there's good data that the projected growth for the Hispanic population between 2014 and 2060 is increasing. I mean, we see how most of the other race are going to shrink a little bit in comparing with Hispanic, especially those of Hispanic descent. I mean, we see on the chart that you have in front of you on the screen how 2060 looks like. I mean, you can see minorities as a group would increase from 48 to 64%, and Hispanic from the 24%. Those under 18 years old to a 33%, and those in general, in total, from 17 to 28%. In Puerto Rico, of course, those of you guys are in Puerto Rico, well, majority are Hispanic. But here, to give you an example, in Philadelphia, right now we have a 6 to 80% expected, probably a 26, 28%. So that's 10% increase in the next 30 to 40 years. That's a lot. That's a lot. And I say that just to think about the other numbers, right? The mismatch that we see with Hispanic communities and the mismatch we see with staff and the workforce. I mean, right now, about, 3 to 4% of the mental health workforce are Hispanic or Hispanic descendant versus the 16%, 18% of the population. So that's a huge mismatch about, who is going to take care of these patients or who is taking care of these patients at the moment. Demographic and societal issues. By 2060, the number, as we said, Latin and Hispanic people in the United States projected to be, almost 30%. So that's almost 1 out of 3 people. 62% U.S. Latinx Hispanic people have a Mexican background, followed by almost a 10% Puerto Rican background. 19% of Latinx live in the poverty. So we know, as I see in my nonprofit, 85% of my patients are either Puerto Rican or Dominican. We have 5% that are immigrants, and then the 10% is African Americans with a minority of Caucasians. But of those, I mean, of the 85% of Hispanic, more than half of them has either live low income or have low education, and some of them have no insurance. So especially among older people, and we see this problem. Also, there's the fact of stigma, right? And most of our patients are seen by a primary care physician before they see a specialist. So there is a big delay in between getting treatment for a mental health disorder or a substance use disorder due to the one, lack of insurance, second, language, right? When we talk about that, when we talk about barriers, but the stigma of the community or where to look for help. Also, as Hispanic, we usually wait until the last moment to look for help, until things are falling apart and we have no other doors, or the doors are closed. Now we decide to look for help. So that's something that, as a cultural, we need to include in our treatment plan and work with our patients, and not waiting that long or until it's too late to get treatment. This is a really interesting report, and I invited you guys to see this on the website. I mean, the report. For Hispanic, they do this with most of racial minorities. They started doing this in 1985, and this report comes out every other year. I mean, this information is from 2018, but if you see most recent disparity, so we're talking about the last report versus the new report. So we have done good strikes in some of this. I mean, cancer, cardiovascular disease, diabetes are improving, but when we see mental health, we're worsening, right? I mean, 25%, so a few years ago, 75% worse from previous report, and then from last report to this report, still a 25 worsening. So we see about the trending on cancer, cardiovascular disease, diabetes is that we are improving, but the trending in substance use disorder is like there's either no change or the improvement is a lot less. So we have a lot of work to do in terms of mental health and substance use disorder for minorities. There's a big prevalence of substance use and serious mental illness in minorities. The Hispanic communities, yes, we suffer not from more of the mental illness or more of the substance disorder. It's just that when we look for help, either the mental illness or the substance disorder are so severe that it's hard to be treated. So again, we wait longer to look for help. We do a really here in America, in general, we do a pretty bad job in preventing, better in treating than preventing disorder, and we do a even worse work when we talk about minorities and preventing disorders. So in that round, so we are talking about that, yes, Hispanics, when you compare to Caucasians and when you compare to African America, it's not that our populations are sicker, is that when they are looking for help, it's either too late or the severity of the disease is a lot higher. Also, we suffer from more comorbidities. I mean, once it's really hard to see, someone with only mental health. Usually we see, people with diabetes, hypertension. So there are multiple comorbidities, and we need to work with that multidimensional model to treat that patient. And of course, when we add, the insurance situation, the language situation, the lack of services for Hispanic communities in their language and culture, that worsened the situation for some of the clinics and the health system in general. So even though, I mean, Hispanics, when we talk about, I keep saying Latinx and Hispanic communities, you guys know, right? Those are you guys that are Hispanic and work with Hispanic, you guys know that not every community is the same, right? I mean, when we talk about Hispanic, I'm including them all, right? But when you talk about Puerto Ricans versus Cubans versus Dominicans, I mean, their needs are different. And I'll give you an example. So under our nonprofit, we have 3 clinics in 3 different zip codes. Every community in those different zip codes and the way we structure our clinics is different, even though they are walking distance to each other. So the difference between a Hispanic community in one zip code is a lot different than that zip code. Especially, so imagine that when we're talking, if the zip codes are different, imagine when we're talking about countries of origin, right? So treating a Puerto Rican, it might look different than treating a Cuban or treating someone from the Dominican Republic versus treating someone from South America or Central America. So that's something to have in mind when we're talking about training to staff and this kind of webinars. So give you a little bit of numbers here. So comparing to between Puerto Ricans and South Americans, so Puerto Rican have the highest rate of recent illicit drug use, comparing 7% to 2%. So we're talking about 3 times higher the rate of recent illicit drug use. Also, Puerto Rican have the highest rate of recent marijuana use comparing to Cubans and South Americans. Other Hispanics, I mean, individuals originating from Mexico, Cuba, Puerto Rico have the highest rate of recent cocaine use, versus Cuban. So just to give you an example of how different ethnicities have different needs, even though we're calling them all Hispanic or the Hispanic needs. More information about this, just to show you, I mean, how disparities can change over time and how we need to do a better job in terms of disparities and care for our minority groups. In terms of mental health care for Hispanic adults who received mental health treatment on counseling in the past 12 months, so that worsened. From last year, that there was no change from the report before the last report. There was no change. In the last report, we found that it was worse. Also for adult major depressive disorder, it was worse. Children ages between 12 and 17 with major depressive disorder, it was worse. So we're not doing a good job in terms of adults or kids. Yes, we saw a better job in terms of suicide death. So, and that can be explained because of the marketing that we're doing in terms of, adding the hotlines and adding the chat and the blogging and really doing a better marketing in terms of suicide and prevention than other, individual disorders like substance use disorder or major depressive disorder. It is difficult. Yes, it's a difficult task, but it's not impossible. Let's talk a little bit about the barriers. I mentioned a few of them, but just a little bit in more details. So Latinx Hispanic people are more likely to seek help for a mental health disorder from a primary care provider. Yes, we talk about that. I mean, that compares to a 10% versus a 5%. Even though they look for help, sometimes they do not receive the treatment because the health system is not prepared for that patient in terms of language, in terms of transportation, in terms of cultural competence. There's a difference between speaking the language or using an interpreter versus understand the culture and tradition of that patient. So that's why we need cultural competency training for staff, right? It's not the same. It's not enough to speak Spanish, right? To treat someone that speaks Spanish is also important to understand where the patient's coming from, the family structure, transportation issue, the job they have, and other situations. Poor communication with healthcare providers is often an issue. Most of my patients either have an issue with someone that didn't understand them when they call, or the communication was broken, and I see that a lot. The example is they go to the PCP, they explain some of the labs, and they misunderstood what the PCP said because the PCP didn't speak English, and they come to us, to the psychiatrist, and they say, hey, this is my labs, and they was like, well, I don't think that your PCP meant to say that. So again, there is miscommunication there. We put a lot of stress in our patients in terms of, if they misunderstood a lab, right, and they think that they're sick and they're not sick at that moment. That put a lot of stress on them, and a lot of stress that is not necessary. Mental health problems can be hard to identify because Latinx Hispanic people will often focus on physical symptoms. Yes, we see that a lot. That's why it's very important to, major depressive disorder can present with a lot of physical symptoms, like headaches, stomach ache, and also change between an adult and a kid. So it's really important to understand the cultural and where the patient's coming from. 18% of Latinx Hispanic people do not have health insurance, which is, of course, is a barrier, big barrier for our communities. And not all clinics have the chance or the options of seeing people without insurance. 90% of people over the age of 12 with a substance use disorder did not receive treatment, and this is something that's real for Hispanic and non-Hispanic. Even substance use disorder is usually a big barrier in terms of treatment, maybe because of the training of the staff or the access to the treatment. But there are some solutions. I'm going to talk about a patient of mine. I changed the name, of course. His name is not Augusto. I just like the name Augusto. I think it's my wife's favorite name for a male. I don't know why, but she likes Augusto. So let's put his name is going to be Augusto. So he's 17 years old, Spanish speaking, Puerto Rican boy. Mom is Puerto Rican, father is Puerto Rican. And right now he's living with with his mother and sister. They moved to Philadelphia after Hurricane Maria destroyed their home. His father was physically abusive towards him, and his father left 3 months ago. The father was the only one working at that point, so the insurance went with his father. So now that he has no insurance, mom is not working at present, and she's applying for the Medicaid option for the kid. Augusta has been using heroin, cannabis, and cocaine for 2 years. Even before they, so after Maria. So Maria was what, 2017. So he started using after the stress. While he was in Puerto Rico, he moved here, and that became worse. His use became worse. He can quit whenever he wants. That's what he said. And now he's ready. He wants to do better. So he's accepting medication. He's accepting therapy, and wants to do better. He was able to stop using the marijuana, able to stop using the cocaine, but having some issues with the heroin still. He has tried buprenorphine for opioid use disorder, but it has not worked. Also, there's some ambivalent about trying something different versus staying on the buprenorphine versus the fact that he might be selling it on the street and not using it or taking it as prescribed. He's missing some appointments, and mom is pretty mad about his lateness and not doing anything at home. So per patient, she kicked him out. Now we found out that his girlfriend is pregnant, and he shows pretty afraid, of course. So some observations about the case. The kid only speaks Spanish. He has a substance use. Pregnant the girlfriend is now pregnant, which is an addition to the stressors we have. He has no insurance, right? Possible homelessness and missing appointment at school. He's only 17 years old. So treatment for adolescent and substance disorder are usually pretty limited in terms of medications, because we only have the Vivitrol, we only have buprenorphine, methadone is a little bit harder if you're a minor because of the federal regulations. So, but I'm pretty sure we all agree that healthcare should be safe, effective, cultural humble, cultural sensitive, patient-centered, timely, and equitable. So we need to offer treatment for this for Augusto as he needed. So we're gonna bring Augusto later on, but so as we know, what kind of barriers we see in Augusto other than not having insurance, right? We know that Hispanic, when you compare 2013, 2018, we have seen an improvement, right? But still, there is a lot of Hispanic that have no insurance. We see with Augusto and most of our Hispanic patients barriers in care, barriers that can be divided in the individual, community, and societal. The society has. When we talk about barriers in individuals, we talk about the stigma, cultural barriers. There is some masculinity in the treatment we're looking, right? The waiting that I can do it myself, as Augusto said, I can do it myself whenever I want. There is some masculinity on that. There's some violence, trauma that's pretty not that uncommon to see trauma. With Augusto, we see trauma from one losing their home, right? For Maria, and I see that a lot of our nonprofit, both a nonprofit, Crear con Salud and APM here in Philadelphia. A lot of our patients came after Maria because they lost everything, and they present here with no plan at all, no home, no insurance, no school for their kids, and that's that's a stress itself, but that's trauma, and trauma could be generational. It could be different generations. In this case, could be mom, dad, but also Augusto and the sister, of course. There is a lack of knowledge about and awareness about what was available for them. In terms of community, we see a lot of shortage on cultural and linguistic services. In this case, if I was the only Spanish speaker psychiatrists in Philadelphia, it would be really hard. There are not a lot of Hispanic speaker psychiatrists in Philadelphia, but we are only a few. So there is a really shortage of qualified mental health professionals. There is also a shortage of academic and school-based mental health programs. And we see this in different states. And I think this in the nation, I think this is a big problem. So there is not a lot of academic and school-based mental health programs. So if Augusto is having an issue at school, it's really hard to identify that issue, prevent it, and refer to treatment. So we wait until the patient start missing a lot of days in school to get that help, versus having a program and being able to identify when it's happening and not when it's already happened. That's why we have so many kids dropping out of school. And of course, the structural barrier to care. In terms of society, we saw a lot of social and economic resources and living condition. I mean, when our patients move, as Augusto, I mean, looking for a home is not easy, so they get in waivers, they get in Section 8, and that's a waiting list, right? It's a waiting list. The waiting list can be as long as 2, 3, 4, 5, 6 years. I had a patient waiting for 8 years in a homeless shelter waiting for housing. So affordable housing is almost non-existent in America these days. So these waiting lists are long, especially when we're talking about families, when you're talking about females, when you're talking about female with kids. We have family shelters, but that's waiting list is a lot longer on those. Transportation is a big issue. That's why we have, in terms of APM and the nonprofit, we have clinics pretty close to the community we serve. Because if we put the clinic too far, they will not come, right? Most of our patients walk to their appointments. Telemedicine, yes, is a great tool. But then we talk about Wi-Fi, infrastructure, having the tablets, having the computers, and the video takes a lot of the weight, the power of the connection. So we need that infrastructure to help our communities. But yes, telemedicine is a pretty good tool for our community. There is a social exclusion. I mean, probably you don't see that in Puerto Rico that much, but you see the segregation of communities. I mean, you can see it in Puerto Rico, of course, depending on socioeconomic status that the patient live. But there is a pretty decent marked segregation between communities and Hispanic communities, and even within the Hispanic community, there's some segregation between Puerto Ricans, Dominicans, and South Americans in any state you go. And that decrease the access, that decrease opportunity for treatment. And of course, in society, we have a shortage of mental health professionals in general, especially those that understand the language and in the cultural. Social barriers. There's legal status for those of you guys serve immigrants. There's the deportation risk. I mean, some people are afraid of looking for help because they're afraid of being deported. There is acculturation. So the predominant culture of the place they live can play a role in the mental health. So if we live in Puerto Rican versus a Cuban versus a Dominican versus an Asian community, the looking for help can be delayed because of the culture of that place. I see that a lot with my patients that are Hispanic but live in Asian communities because of the Asian, there's a lot of stigma and waiting for treatment, and they usually kind of treat their own on that community, but that Hispanic that live in that community, it takes a little bit longer for her or him to look for help. Also, the stigma of not seeking treatment in general. So some research found that the ability of cultural relevant services increase Latino service utilization. So we know that. I mean, we know that increase in services that are cultural, humble, cultural sensitive increase the Latino services utilization. So we know they're going to use it if it's available for them. We know the patient and therapist mutual trust is really important. I mean, we are based in that, we are family-based culture. So we trust our primary care physician. We trust the people that look like us, that talk like us, like move like us. That's pretty incepted in our community and traditions. Speaking a client language is crucial for mental health treatment. Imagine doing therapy without speaking Spanish or speaking the language. I mean, that's in my mind, that's impossible. I mean, it's really hard. Maybe not impossible, but it would be really hard to do psychotherapy or good therapy if you don't speak the language. And many immigrants, right, experience discomfort in this, not discussing and talking about their experiences if they feel you cannot put yourself in their shoes. So how, I mean, this is, I mean, hey, Hector, you're talking about a lot of bad things. I mean, what is good about all this? So there is some improvement. Of course, there is some improvement and ways that we can help our communities. Early intervention is really important in evidence-based community to identify, ways of improving mental health. So implementing, and one of the questions was about mentorship and peer-to-peer groups, right? And such as peer support and mentoring programs, family psychoeducation and curriculum. I mean, we need to include the patient is part of the team. That's yes. It's a patient should be patient-centered, and we need to include the family as part of the team as well. We need to do more of the community capacitation, building, promote the connection between community-based research, and there is good data about why Hispanic communities do not participate in research because they don't feel included. They feel that research is outside their community and it's not community-based. Also, it's not structured for them to, miss work or transportation. So we need to do more of that community-based research to understand our community. Give an example. I mean, sometimes when I meet with community leaders, I, do research about them and I meet myself or I meet them when they are, because you don't want to present as you're going to save that community, because it's not true. You're going to work with them, right? You're going to work with them, and the plan should be together as a team. And of course, we need more academic and school-based mental health programs that are structured for Hispanic communities. And you see that a lot in Puerto Rico and other programs that we try to implement protocols and policies that are not created for Hispanic communities and that are created for Caucasians or African Americans or Asian communities, and we want to try to implement those, and it doesn't work. It doesn't work. We need to stop doing that. So we need more cultural sensitive, more cultural competent policy that have been studied for Hispanic community or has been translated not only in language, right, but also in the cultural sensitivity of that community. When meeting with a health professional, ask them if, and if you are staff, you're a patient, or you're a leader, please ask them. I mean, have you treated other Hispanic, Latinx people? I mean, have you worked with communities, Hispanic communities? I'm from Vieques. I'm from a small island. I mean, I just going to San Juan, right? People from Vieques are not the same as San Juan. I lived in San Juan most of my adulthood. I mean, high school. I did high school in San Juan, but I'm a Vieques kid, right? I'm a farm guy, and so it's different when I go to Vieques to do community programs. My community programs are going to be different, tailored to Vieques needs, and when we go to San Juan, it will be different. Maybe the same program, same principle, same objective, but the implementation, the structure that we use is going to be different. So even though both communities are Puerto Ricans, we think about, how are we not only giving the training, but how is the training going to be received? So that's really important. Other question that you can ask, and you should ask, is have you received training in cultural competences or Hispanic Latin mental health? And those of you guys that work for the institutions or national-wise and this big institution, they're adding those to that training. You can see the DEI training, right? The diversity, equity, and inclusion training. I mean, that's really hot right now, and you will see that on the training before even you start a new job. So how do we implement those, right? And I think that's the piece that we're missing, right? That's what we talk about peer support. That's what we talk about mentorship. Because you need that constant training, that experience, that practice in terms of implementing what you know. only than just checking once a year, a few boxes. And also, how do you see our cultural background influencing our communities and my treatment? So you need to, ask yourself how your own bias or how you perceive yourself in that community. Some models to help with that. I mean, people talk about personalizing and precision medicine for Hispanic communities. Those of you guys that are prescribers or prescribe medication, I mean, there's a lot of biomedical research out there, clinical medicine. We're doing a lot of genetics study that we can send genetic and save that medication. It's good for you, and that gives you a good idea of, how biogenetic and can help with the medicine. I mean, the present and the future of medicine, because now we can select medication that work better in Hispanic genetic, and the Hispanic genetic is different from Puerto Rican versus other Hispanic, Dominicans or Cubans or South Americans or Latin Americans in general. It's different. So having those tests, studies, and research on hand really will help to do a patient-centered selection of medication. So that's something that's available. Also, the genomic and epigenomic of having a knowledge of where the patient is from and the background of the family to really help with that. So we need to keep doing research. So that's a recommendation, right? Including Hispanic community-based research to get more information on how we can improve and patient-centered and personalized treatment. In terms of including all the map, I mean, there's a good cultural gram of mapping the role of culture. And as you see, I mean, all these things around the family and the member are important. I mean, the legal, the socioeconomic status, the time in the community, right? It's not the same. Augusto, for example, I mean, he's from Puerto Rico, but now he lives in Philadelphia. I mean, what community in Philadelphia he live in? I mean, that's really important. Communities in Hispanic communities from Allentown versus Philadelphia town are different communities. So we need to make sure that we understand the zip code, the area that he lives or he's living at, and how that change, right, is affecting Augusto. The language he spoke at home versus the language he preferred. I have patients that they do not want to speak Spanish at home because they feel that the kid is going to have an accent. I mean, well, that affects the view of the kid about the language and then how he presents in school about that, around that, right? So now I have a kid that doesn't want to speak Spanish because he feels judged by others. So that belief, we need to talk about it. Health beliefs, impact of trauma, of course, values at home, values at school, really important. I mean, the values of a grandma or a grandpa raising the kid are going to be different than a young couple raising the kid. I mean, we need to identify that as well. And all of that could be part of the formulation that you do about and the assessment you do about that patient. More information, you can find it at tip 59 from SAMHSA. It's great. It's called Improving Cultural Competence. It's a big book, but it's really helpful. Other thing that you can use is the multidimensional model for developing culture, and you can use this with staff. And they did a great job with this because I mean you can use it for all races. I mean not only Hispanic communities, but and what it does is that staff, right? I mean how the staff see himself, and also how that staff see himself in this program, right? In this clinic, and how the staff see himself in the organization. Right? And now we divide that in cultural awareness, cultural knowledge of the behavioral health, knowing the general knowledge, and now on behavioral health and the cultural skill development. So I think that's a great skill to have with all staff, and you can use it again. You can get this from tip 59, but I really recommend that we do it. It's like doing a 360-degree development assessment of your staff in terms of cultural awareness, knowledge, and development. Something we use at APM, Asociación Puertorriqueña en Marcha, the nonprofit I'm a medical director for, is that we like to see our patient as part of a bigger circle, right? So we have the child, we have the family, we have the neighborhood, we have the city, we have the nation, right? And they all belong to a different background. So we like to see the neighborhood as a, and how they fit on that neighborhood in terms of civic engagement, the housing, the commercial development. All that has something to do with the mental health, the health of the patient. For the family, the benefits of counseling versus financial planning, supportive housing, affordable housing. If you have someone feeling safe in their house, most likely they will feel safe in other places, and most likely they will feel safe to look for help, right? Or trust you, and the mental health, the depression, anxiety will decrease, less medications, less weight gain, less this and that. So, I mean, it's a more stable situation for the family in general. And if you have the family stable, neighborhood, then the city, then the community and society will benefit from that. Some other help, I mean, we talk a lot about, I mean, this is a pretty hot topic now with this suicide prevention is a 9AA implementation. I don't think it's coming until like probably end of the year or next year. But now you can call, as you call 911 for emergency, you can call 9AA as a suicide prevention 3 numbers number. There's also some T-Talk or Talk that's for substance use. For minors, they have a good chat, and it comes in Spanish, comes in English, so you can, and that belongs to SAMHSA, so you can go blog and talk to someone on the other side, and that someone can assess and look for places around you, right, and the zip code, and link you with services at that moment. I mean, SAMHSA has a great gamma and options in terms of brochures and booklets about different topics. I just include the depression for mothers and pregnancy, during pregnancy. I mean, that's a great one. I use it with my patients. Those of you guys that like apps, I work on an app that's called BUP. For those of you guys that prescribe buprenorphine, it's in Spanish, it's in English. It gives you 3 days of good information for the patient in terms of inducting them on the buprenorphine and substance use disorder. So, I mean, I'm just mentioned that one because there's good technology out there that is cultural competence, cultural humble that you can use with your patients. And of course, SAMHSA has a great manuals around this. Please support your nonprofits. I'm mentioning mine. I'm biased, of course. I love Cleric and Salud, but just I mean, use them. I mean, talk to them and support them, because we see that during the Marias, right? Nonprofits carry the part of a big burden in terms of carrying, be present during the mayor situation with Maria and the needs of the community. Of course, we need private institution. We need the public institution to work together. But please support your nonprofit organizations. Some recommendation for staff. I mean, establish cultural competence committees. I mean, mentorship is really important. Link someone that knows more, have been longer in your institution with someone that just starting. That really help. Develop local outreach educational programs with nonprofit, private institution, with the state, federal government. I mean, SAMHSA has a lot of good programs. The Opioid Response Network is like a really good one that is sponsored by SAMHSA. There's something called PCSS as well that you can, put consultation for free, and you get a link with a mentorship. Going back to Augusto, I mean, what do we do for Augusto? So we talk about Augusto through the presentation. We know that he only speaks Spanish. He has some substance disorder. I mean, pregnant girlfriend, or trauma. So when we talk about Augusto, I mean, I like to see Augusto as, I mean, you're trying to implement all this that's surrounding Augusto in terms of language, health benefits, I mean, the values at home, homelessness. And of course, Augusto has a lot of risk factors. I mean, risk factors that we see in our communities, I mean, the racism, the oppression, but there are also protective factors we need to look and help Augusto. I mean, the neighborhood attachment that we can create with Augusto at this point in terms of new place, new life, I mean, he's starting a family. So how is the family connection? I mean, what's the situation with the girlfriend? Is this baby wanted or not wanted? Why keep using heroin, and why were you able to stop cocaine, marijuana? So all those, failures versus good things, because I mean, he has done good things. He stopped using cocaine, he stopped using marijuana. He's not suicide, right? I mean, so there are good things happening. And he's a good relationship with the girlfriend, not with the dad, but he has a good relationship with the girlfriend. Maybe mom can take him back if he takes the Suboxone, the buprenorphine as prescribed. So all that needs to be discussed in terms of, but we need to engage the school, the family, and caring, and see all this domain as one. For kids, I mean, there's recovery high schools, there's peer group support, there's some faith-based organization, 12-step for kids. Of course, there's medications as well. And there's a lot of opportunities, right? Help the communities, system serving youth, school and child welfare. There is the Justice Department. I mean, some people are afraid of the Justice Department. Yes, you should sometimes, but they sometimes really help in terms of structuring your patient. I mean, depending on the relationship you have with POs, probation officers, and the department, it can be really helpful. There's a lot of social emotional learning. Augusto is going through a lot of transition in his life, and we need to create relationship and connections. So hopefully you can use some of these models or all of them to create some cultural competence and humility. So I'm gonna stop here. I think there are some questions. So some of the references are here, and I guess the microphone is open. Thank you. Thank you for your time.
Dr. Colon, thank you. We have a quick question here. Could you repeat the name of the app you mentioned as a resource?
Oh yeah. So it's BUP, and it's for people that are being prescribed, buprenorphine, and it's a good 3 days checklist of everything you have to do. So you can work on your withdrawal symptoms and how to start the Suboxone or the buprenorphine. I mean, that's just one example, right? There are multiple apps out there that can help our patients. Of course, there's some for CBT, cognitive behavioral therapy in Spanish, and other type of therapies.
Thank you. I would like to remember participants that you can share your questions through the question section. You can share, we'll read it out loud and answer it. Also, the materials for this presentation will be available after the presentation in our website. You can download the slides for it.
I will go ahead and read one question here that Dr. Colon may help us with. Is there any trainings or learning opportunities that you would recommend related to behavioral health crisis services?
I mean, there's always the first aid for behavioral health. I mean, that's a good one. It does help you to identify and try to prevent, right, any mental health or substance disorder. I mean, right out of bed, that's something that, I mean, probably SAMHSA have different ones on the website. I mean, I don't have anything in mind, but I think first aid is a good one. And every organization have something. I mean, if you look at psychiatry.org, I mean the APA website, they have been able to create some tools, and those tools are pretty good. I'm the co-chair of some of those tools, and just go to psychiatry.org and search for Hispanic communities, and you will see a good amount of tools that you can use for Hispanic communities there. We're also creating a website that will be part of the APA, the American Psychiatry Association, and it will be in Spanish. So probably by the end of the year, it will be available. We're working on some cartoonish videos that explain some of the symptoms of different disorders. I think we are working with substance use, anxiety, OCD, and those will become available probably by summer. We're adding a lot of tools. So check the psychiatry.org website. They have good good tools there, and we do webinars pretty often on that too.
That's great. Thank you very much, Dr. Colon. I would also we can add this to a chat briefly. The suicide safe SAMS app. It might be also a good option as an app for behavioral health crisis, which has its own case studies and conversation starters to work through with clients and patients.
Also, I just share with the participants the link for our website where they can find the material after the presentation. I will be sharing with all of you the evaluation, which is very important to us, which help us to continue to provide these trainings free of charge. I'll paste that link. It will be only take 1 to 2 minutes, and we will greatly appreciate your answers. I'm posting that on the chat right now.
Sure. I'm gonna post my email in case someone has a direct question to me. I mean, I would be happy to help.
Participants can now access the evaluation through SurveyMonkey link I just shared with everybody. Also see a question here. We will be having the certificates we send directly to your email after the presentation is over. It only takes 1 to 2 hours afterwards. Yes, we have another question. The presentation is recorded and will be posted also with the slides in our website that I just shared. Once again, I'm sharing the evaluation through the chat if anybody missed it. Participants are mentioning that they did not receive the evaluation. I'm sending them once again. You can look through the chat.
I'll go ahead and as we answer this final question from one of our attendees, make sure please that as you see in the screen to fill out our evaluation. This question addresses, as Latinx service providers, how do you think we could help our co-workers who are not Latin to be better equipped to serve these communities? Dr. Colon, we can hear. Yeah, there you go.
Yeah. That's a great question. Because we want those people that are interested in helping us. So again, I mean, one thing is please invite them. I mean, to these kind of webinars. Talk about the topic. I mean, what kind of question they have. Their books they can read. Their webinars they can go to. Serve as a peer, serve as a mentor, sit with them with patience to see their interaction, give them feedback, and that's really important. I think having webinars and having practice sessions, kind of giving feedback to those that want feedback, I think that will help, and give the chance to work with the community. If it's not with individual patients, I mean, give them a chance to go to community events, learn about the cultural, and share your experience with them. I mean, I like that. I mean, mentorship, linking someone that's really interested in working with Hispanic community with someone that's already working in Hispanic communities, I think that's the way to go.
Well, thank you for that question. Thank you for the answer, Dr. Colon. I would like to say that would, for now, for the time, would conclude today's webinar. We would like to thank you, Dr. Colon, and thank you all for joining us today. And please stay tuned for our further materials and surveys. Thank you.
Thank you for the invitation.